Be exposed oftentimes to strobe lighting and then told, okay, now close your eyes and go to sleep. And they would rest, sometimes doze off for 10 or 12 minutes, and then wake them up, done, on to the next, right? There were a lot of reasons for that, but most of those reasons don't matter anymore. I don't even bother with a 20-minute EEG. The reason is because EEG, the major limiting factor of EEG is sampling time. I have patients who with epilepsy, who have very frequent seizures, and they may have a normal EEG during this 20 minutes, and they may have a seizure during that 20 minutes. And the longer you can stretch out the EEG period, the duration of the study, the more reliable it's going to be. You just have more data to look at. So the first point I would make is the sensitivity of an EEG for picking up abnormalities, and here we're talking about largely epileptiform abnormalities, really comes down, one of the critical factors is how long was that EEG. I generally start with a 45-minute EEG, and if that's 45 minutes to an hour, depending on what I think the compliance of the patient will be, and then if that doesn't answer whatever the question is, maybe the question is, can this person come off of medications? Maybe the question is, does this person have epilepsy? Maybe the question is this medication working? Are they outgrowing their ESCS? If that outpatient 45 to an hour EEG doesn't answer the question, I go directly to a 24 or 48 hour, generally an in-home or ambulatory study, although that can be done in the hospital as well. The major difference between in-home and ambulatory, well, there's several differences. We can get into that later. I don't want to dart things now. But the point I'm trying to make is the duration of the study is one of the most important aspects of obtaining an EEG. And I find 20-minute EEGs to be not very helpful. Second piece is the reader. You really want to have somebody interpret the EEG that is qualified to do so. That is to say, they've had at very least, a fellowship in clinical neurophysiology, which means they would have read about 3 or 4 months of EEG, have dedicated training time for 3 or 4 months of EEG in their year of clinical neurophysiology, but much more desirable would be to have an epileptologist treatment, because an epileptologist has spent 2 years generally in the old school, like me, but even in the newer ones, at least a solid year, full-time reading EEGs at a much higher volume with both adults and kids and inpatient and outpatient, and they're just exposed to a much broader variety of patients and circumstances for reading and interpreting EEG. They also train generally in an epilepsy program under experienced EEG readers who've been doing this for 20, 30, 40, 50 years. And it's hard when you have a large volume of work.